Hi, my name is Dr. Jennifer LeComte. I'm a Med-Peds physician at Rowan University School of Osteopathic Medicine, Rowan-Virtua School of Osteopathic Medicine, and I'm excited to join you to talk about transition of care. I will specifically be focusing on longitudinal care for adults with childhood onset conditions and different abilities. And I'm hoping that we can get a lot of your questions answered about that process. I am a Med-Peds physician, so I'm a pediatrician and an internist, largely focusing on adult care, and you'll see why that's necessary as we move through the presentation. So our objectives today are going to be to discuss healthcare transition. Unfortunately, there are a lot of barriers, so I'm going to list them here and hopefully give you some solutions to overcoming those barriers. I equally want to discuss how we can collaborate so these transitions can be more successful, so our patients can be more autonomous in accessing healthcare. And as we move through all of this, I'll bring in some evidence-based medicine and some of the healthcare literature, which is still growing, and I'm hoping that our processes can help us contribute to better health outcomes for the people we care about. So I don't have any disclosures, at least none really. I started this work back really in my residency, but probably before that. So a little bit more background about me. I worked at Bancroft Neurohealth after I left college before I entered into medical school. So I was already interested in working with people with different abilities, and then went to medical school. And fortunately, my brother had a child 8 years ago now. So this is an old picture, who has Down syndrome. So I have a personal interest in making sure that transition care for people with different abilities happens, especially here in New Jersey, because that's where my little Danny lives. So he's 8 now, so that's nothing to fully disclose. I don't make any money off of it, but certainly open to those prospects as well. So let's start with the good news, and there's still lots of good news about care and healthcare. Believe it or not, it's not what we always hear, but children with chronic conditions and chronic health conditions, childhood onset complex medical conditions are surviving into adulthood. Our technology, our science has really advanced that allows folks with really complex conditions to become adults. So when I wear my pediatrics hat, I can celebrate that we get folks with sickle cell disease and cerebral palsy and autism into adulthood. For some conditions, we hope they age out. So we hope asthma doesn't progress dramatically into adulthood, but we know it can. We equally know that things like ADHD definitely do carry over into adulthood, but perhaps access to medicines because they're controlled substances, etc., can be a little bit more complicated. One of the reasons that I entered into this field is because I understood that we were having many successes. So we have a lot more survival. Folks with sickle cell disease used to die in their teens in the 70s when I was born, and more than 85% are surviving into adulthood. We actually have more adults with congenital heart disease that are cared for in the adult population than our new diagnoses are finding. So our opportunity to care for these folks in the adult world is actually growing every day because of the successes of pediatrics. I always like to point out childhood cancer survivors. A lot of my folks who are cancer survivors forget to tell me about their childhood cancer because maybe they didn't know, but their survival rate is really high. But the unfortunate part of that is more than 25% of those adult survivors actually have a life-threatening disabling condition, but doesn't come until 25 years after their treatment. So adult physicians really need to be mindful about childhood diagnoses so that we can monitor for these and mitigate any of those problems. Unfortunately, because we don't always communicate with our pediatric colleagues, we can have pretty adverse effects for serious conditions. Just one of the data points here, for folks who received a kidney transplant in childhood, sometimes they lose access, stop taking their immunosuppression meds, and then unfortunately need to have another transplant in adulthood. So when we don't do transition well, we unfortunately can have bad outcomes. For our folks with type 1 diabetes, oftentimes they'll access more care in the emergency room and not transition appropriately to primary care so that we can really maintain the successes that they've had in childhood. More specifically with people with intellectual and developmental disabilities, we do see higher rates of chronic conditions with poorer access to care. And again, like I pointed out in the previous slide, they're hospitalized more for longer periods of time with more tests that maybe aren't necessary. The biggest thing that I address as a primary care provider is the reduced rates of access to preventable health care. So those are things like just getting your immunizations, reproductive health exams, mammograms, colonoscopies. So those preventable access to preventable medicine and the reduction of that for people with different abilities actually increases the likelihood that they'll die 4 times more likely than your general population, which is, again, preventable. So that's largely where we'll speak throughout the presentation. So I think that New Jersey, especially in South Jersey, where I practice, accessing primary care can be pretty difficult. We have a lot of transitions that happen just as our children age out of high school and don't want to go to their pediatrician anymore. There's lots of people looking for primary care. And so we often get parents saying, my son is aging out of pediatrics and can he come to you now? You're my primary care doctor, whether that's family medicine, internal medicine. He's healthy. Are you able to take my child into your practice now? And we are also hoping that our children are also becoming more independent and maybe accessing that care themselves. The reality is that a lot of our practices we have aging primary care doctors. They're not taking on any new patients. It can be pretty challenging just for any neurotypical patient to access primary care. Well, let's change the scenario a little bit. And now we have someone coming to me and saying, well, my adult son has Down syndrome. I've already called around, and I find that a lot of our families say, well, he's actually healthy, and he doesn't have any heart issues, so can you take him then? Because as we add complexity, I think families are feeling that they're going to be sent away, and then obviously if you add any behavioral health needs and the limited access we have to mental health and behavioral health services, especially in adulthood, that can become even more frustrating for families. And also families come with a lot of information and they want to be with physicians who understand childhood onset conditions, and we don't always get there. So if you're asking your own primary care doctor to take on your medically complex adult child, what you're hoping for is if they can they at least refer you to other folks. And so I'm gonna hopefully give you some resources that you can find that as well. So I'm gonna show a little video. When I first came on talking about with our medical students and residents about the patient population that I love to take care of. The title of the the talk was the difficult patient, which, as you can imagine, isn't so engaging in hoping that future physicians will take on this patient population. Certainly challenging, certainly complex, but I think that even just changing that terminology, which I have done now that now we talk about etiquette for caring for people with different abilities. So I'm going to show you a quick video.
He has ripped one doctor's pocket off his shirt. He's bit a couple of other people along the way. I hear him now. Oh my goodness. He's mad.
People with intellectual disabilities have a very difficult time accessing good quality health care.
It's not uncommon to hear a parent or a guardian say, the last time we went to a dental office or a medical office, we were told, get your son or your daughter out of here and don't ever bring them back. Our professions have turned their back on them in many cases.
Well, recently.
So unfortunately, I have heard these stories from patients who have found their way to the Rowan Integrated Special Needs Center, for where I am the medical director. And this video is actually from quite a few years ago, and I still find that these stories are pretty prevalent, unfortunately. But I'm hopeful that with further education,
An ambulance refused to transport.
We can overcome that. So one of the reasons why these transitions are so challenging is it's a pretty complex web when you're adding in all the agencies that are required to get through a transition. This came out of Children's Hospital of Philadelphia, again, one of the tertiary care centers that refer our patients who have to cross the bridge to access care. And certainly we're trying to make sure that access in New Jersey is improving. And we're working on that. But again, this web of communication can be fairly difficult. You have home services, you have school services, and employment. Some add residential services in here, and then you have to talk to all your pediatric providers to make sure they get over to the adult providers. But there aren't always equivalent providers to pass that information along. For example, for our patients with cerebral palsy, I trained at AI DuPont Hospital for Children, Nemours, and the medical home for patients with cerebral palsy was the orthopedic department. And many of my orthopedic physicians in the adult world don't take care of people with cerebral palsy. So largely they transition to physical medicine and rehab doctors who help work on bracing and wheelchairs and spasticity. So we don't always have an equivalent or direct communication line. And that's why I put primary care in the center here, so that they can also tie in all this webbing to get people from pediatric care to adult care. What we often hear families describe that transition, which should be a process, and we'll talk a little bit more about that, is feeling like they're falling off a cliff. You know, diagnosis is a pretty difficult time for many families. Sometimes even when they get to adulthood, they're still working on what the official diagnosis is. But certainly when it happens, and when they progress through life with their pediatric services, sometimes the first time they enter into the adult world, it could feel like a grieving process, an abandonment process. That's when you do find care, right? A lot of times our families just stay on this line, which becomes sort of stagnant because they can't transition to adult services, or adult services just stop, or I'm sorry, pediatric services just stop and they fall off the cliff. So what we're going to talk about, and I love Pixar because I feel like they always can describe it in a way better way, is let's buy a balloon and start to talk about what that process looks like and how we can make the process better. And hopefully get over to paradise, which, you know, the adult world isn't the dark side. So I'm hoping if we buy a balloon, we can get over to paradise. So you always have to start with definitions. Healthcare transition, specifically pediatric to adult healthcare systems. This came out of the Journal of Adolescent Health, is the purposeful planned movement of adolescents and young adults who have chronic conditions, both physical, medical, and some behavioral health conditions, from child-centered care to adult-centered care. And that's that purposeful and planned that we're going to really target on. Certainly in the healthcare, in the education system, there is if anyone has an IEP, you have to discuss transition by age 14. In healthcare, that doesn't exactly exist. So we do largely use that age to help at least start the dialogue. And again, I think healthcare still has to catch up with some of the systems that have advanced their care. We didn't really have a lot of published data until 2002 about transitions of care. And fortunately, these three big groups got together. So pediatricians, family physicians, and internists got together to talk about what needs to be done for getting children with special healthcare needs to adulthood. And terminologies have changed too. So people with different abilities, complex medical needs, these terms have changed a little bit. So one barrier, and again, we'll talk about a lot of barriers, but one barrier is that this was published in pediatrics. So the people who need to hear this message, like family physicians and internists, they don't read the pediatrics journal. So that can be challenging when you're trying to get more receivers of patients who are leaving pediatric care. So that's one barrier, but at least they all got together and they're starting to communicate a little bit better. And they defined healthcare transition. And I think this truly is a definition that we all want to experience, that we want to maximize our lifelong functioning, right? We all want to live full, healthy lives through high quality, developmentally appropriate healthcare. So developmentally appropriate, I think, is very specific for people with IDD or special healthcare needs. But the reality is that really you can put this in the same category as healthcare literacy. Many of my neurotypical patients still struggle with doctor speak and us communicating directly about what patients need to do in order to participate in their own healthcare. So while this is specifically targeted for a pediatric population, I think that we can do better even with our neurotypical patient population. And the other key for those healthcare that during that transition is that it's uninterrupted. I already spoke to you earlier about when we interrupt that care, we can have devastating consequences, more ER visits, even losing our kidney transplant because we had interrupted care. So I think that we all are looking for this in our healthcare. So not unique to people with IDD, but certainly an opportunity to really bridge the gap. So we need to talk about what the barriers are, identify the steps, and then hopefully bridge those gaps. So in that consensus statement, they identified 6 critical first steps. And I think I've already pointed out that identifying a primary care provider is really the first step to really helping find someone, a patient-centered medical home that can really help navigate these waters. But unfortunately, and this is old data, and I don't think it's actually getting much better. But when we did do a survey, only 40% of youth with special healthcare needs actually could identify an adult primary care provider. And what that does is leaves adult patients in some of their pediatric practices, or it leaves them with no primary care doctor. And again, I pointed out this earlier, but when you don't have a primary care doctor, you visit the emergency department more often, you're more likely to get hospitalized and unfortunately have more things done to you than you need to have done. So I'm going to transition appropriately to more barriers of healthcare, specifically just running through this list. I have some videos to share with you in this section as well. So one of the main problems is for patients who use technology, wheelchairs, walkers, etc. Sometimes just getting into the building can be difficult. And it's interesting in our world of ADA that not all of our buildings are accessible. And I've been a part of already construction projects, and even when we're mindful of those barriers, sometimes we get it wrong. So I had started the transition care practice at Christiana Care in 2011, and we brought in one of our disability services to do an accessibility survey, and we weren't doing very well. So we were able, and we were lucky, we were able to redesign our practice, and we had doors that automatically open to allow our patients to come into our office. But what we found out is we actually forgot to put that same technology for patients to get out. So we had to keep escorting our patients out because they couldn't hold the door themselves. So even when you're mindful of it, we can have some challenges. So when we identify these barriers early, when we're making appointments at new physician's office, making sure that we can at least get in the building. That's a really important question. The next thing is just medical equipment in the office. And for some of our patients, a basic vital sign, actually for all of our patients, a basic vital sign is getting a weight. For those who have a little bit more difficulty standing on a scale, or again, when they use technologies like wheelchairs, they have more difficulty with just getting a basic vital sign that you and I all, while we don't love it, especially in our epidemic of obesity, we know that it's important monitor of health. Again, a preventable cause where you can work on weight loss and diet and nutrition. So if you don't have the appropriate equipment just to get a basic vital sign, that can be a huge barrier for a lot of our patients. Again, speaking about patients with cerebral palsy, some of our patients require feedings through G-tubes. Getting a weight is a really important vital sign to maintain their health and reduce preventable problems. So communication, that's always a barrier, and I think that Justin actually can speak to this barrier better than I can. So I'm gonna again go to share another video. So this is Justin.
An experience happened to me about 3 weeks ago where I entered Cottonwood emergency room about 11 p.m. at night having an anxiety attack. They didn't ask me what was wrong with me. They asked my friends that took me. Now, as I thought I was coming here today to speak with you guys, I thought, now that's wrong. Who's the patient here? So I kind of got stern with the nurse and the doctor. I says, who's in the bed? Who's wearing the gown? Do you see him wearing a gown? No. I'm wearing the gown. Talk to me. It's because what you see a lot of is the people that can talk, they don't get to talk to the doctor. And that's because the parents are either in the room or just being parents and being nosy.
So I just love how Justin can educate us all about how we need to communicate. It can be really frustrating for patients that they don't even get the first introduction. So one of our opportunities here at Rowan-Virtua School of Osteopathic Medicine is that we have medical students that rotate with us, as well as internal medicine resident physicians and family medicine resident physicians. And one of the first things that we teach them is to introduce yourself to the patient first, regardless of whether they use words to communicate, and then open the dialogue with, how does this patient communicate their needs and wants with you? So that can often be just so eye-opening for families, and I would encourage that if it's not already happening in your own experience with any of our medical system. I know that it continues to be a barrier, and I think that if we all advocate for allowing our patients to communicate for themselves, that's in the best interest. Obviously, if our patients use technology to communicate, making sure you bring it to the office. And then when you're making appointments, obviously not so much when you need to access the emergency room, when you're making appointments, making sure that you ask for a longer time if it takes longer for our patients to communicate when they do use that technology. The other unfortunate part is some of the assumptions and the attitudes that we have with patients with different abilities. So making assumptions that someone with cerebral palsy has intellectual disability as well. When I grew up in residency, we would present patients and say that they had MRCP. Well, the good news is we're not using mental retardation as a diagnostic code or terminology, although we still hear it, and that's another barrier that we're trying to overcome. But we also have the opportunity for just not saying, if we not assuming that patients with cerebral palsy have intellectual disability. So getting back to our barriers, another big barrier that I absolutely won't overcome in this talk is just economic. The transition from pediatric to adult care can be very challenging in knowing even what insurances you're going to be able to use in order to both access services as well as just get medical care. And the denials, the prior authorizations, they do seem to accumulate as you leave pediatric to adult world. One example is, I mentioned earlier, is just needing prior authorization for some of the stimulants for folks who have ADHD, finding providers who are comfortable with prescribing controlled substances for those things. But another basic is just acne medication. For some reason, our insurance companies think that acne just stops after you become an adult, and we all know that that's not true. And then, as I mentioned before, some of our folks use G-tubes for both medicines and nutrition, and accessing liquid medications as you enter into adulthood often requires a prior authorization, which if physician offices aren't equipped with enough staff in order to process those things, it can result in delay of care. So there's a lot of social policy that is a barrier for access to care. So again, I trained at Nemours in Delaware, and we had a policy that at 21 you can't access care there any longer, and that was actually a court mandate. And making sure that the patients understood that that was the policy. You also couldn't access, after 18, you can't access a new specialist unless you had permission within the hospital, and that is still true, except for it has some exceptions to that. Other tertiary care centers like Children's Hospital of Philadelphia, they have transition services. They had in the past been less strict about transition, but are more mindful that accessing adult care is really important. And so really creating a process, and you saw some of the data already and why they created that process so that their patients didn't feel like they were going to fall off a cliff. And we can talk more about those resources as we move forward. So other barriers to just accessing care, as I mentioned before, is just sometimes our language is a barrier. And so I've been a part of Special Olympics volunteering for a long time, and I think they've done a really great job of spreading the word to end the word. And Rose's Law also helped this as well, so that we stop using mental retardation and use intellectual disability, and just make sure that we're really changing to respectful people first language. That's something that we teach all the time with our medical students, but I would encourage families to speak up if they are hearing medical providers not use the right terminology, because I do think that your voice matters, and I think that the healthcare system is more likely to listen if they get appropriate feedback on what language to use when referring to the different conditions that our patients come with. So this sort of falls in the barrier of economic. Again, I told you I wasn't going to fix it all, but just being mindful that as you transition from from pediatric care, from school, that there's a lot of services that you were entitled to that you have to then become eligible for, and basically meet requirements and apply for those services and get funding to access those services, like SSI, like DDD, like applying for Medicaid, so that you can access some of the day programs, etc. So this is a big challenge, because it went from entitlement to eligibility. Although I think many of you, if you access ancillary services like speech therapy, physical therapy, occupational therapy, while our patients are entitled to them, we also see a shift even way earlier than 21 of needing to be goal-directed therapy as opposed to maintenance therapy. And so you have to have specific goals, and that's why IEPs and as you become an adult, ILPs, interdisciplinary life plans, are really important for advocacy. And again, we want to have our patients sitting at the table with us, being their own advocate, but this is where many families and advocates should be sitting at the table, physicians too, so that we can make sure that our patients are eligible for the services and know all the services they are eligible for. One resource that can help you with that is Got Transition. So I've been part of their advisory board. It's a national board, and they actually help physician offices transition. So they help people develop policies and tracking and readiness. We just upgraded to a new electronic medical record, which actually has a transition readiness template. The reality is many patients are transitioning to us, and regardless, so it is less of a process and more of an administrative event. We're hoping that if we really can target down to the pediatric population and have our patients really get prepared and families prepare, that transfer, that administrative event has already had all of its training up until that point. But this is a really great resource if you haven't already accessed it, to overcome just that barrier of transition process. So getting back to the, actually, let me just go back just for a second. I want to make sure. Yes, we talked about that. So again, one of the other opportunities and barriers is just provider knowledge. And I've been working with the AADMD, American Academy of Developmental Medicine and Dentistry. Actually, the two gentlemen that we saw in the video are big advocates in that organization, and they have been giving out grants to improve medical education and exposing different professions, especially dentistry and medicine, to taking care of people with IDD more appropriately. And that can definitely help. So hopefully create more primary care providers, but also educate primary care providers on those transition skills. So that's definitely another barrier. So when I first started transition and I became a primary care provider, I educated myself on those transition skills. One of the other barriers was just getting a portable medical summary, especially for those patients with complex medical needs. And we do know that when we incorporate early learners, medical students, nursing students, residents, and we include different populations in their training, they're more likely to incorporate those patients into their practices. And I'll get back to that resource. But there's still the barrier of getting that medical summary. Unfortunately, when I first started, and I'm not sure it's much different now, basically, even when our patients come from group homes, they bring at least one of these books with their medical history, and it doesn't always have everything that I need in it. And it's pretty extensive, and while we definitely want to know a lot of this information, we certainly need it in a more condensed format. You know, I did literally get boxes of medical records like this in my first practice, and this was a daunting task. But just because you can put it on a jump drive doesn't make it any easier to go through all the information. So we still need a way to get this information to our adult providers in a meaningful way. So there's an opportunity to use this portable medical summary as an education tool, both for the pediatrician who's transitioning, as well as the patient and their families, to really understand their medical history, what's important. So, and kind of bringing our patients up to speed on what their actual diagnoses are. I can't tell you, while we understand that phenotypically, meaning how you look, that we would know what Down syndrome looks like. And then we have some of these other quote invisible disabilities like autism. We don't know if a patient can communicate with words or not when we first meet them. It's important that our patients can say what they have as chronic conditions. It's one of my first questions when I meet them, when I introduce myself to them, is why do you see doctors? And that first question can be really eye-opening. And then I say, well, what medical problems or what medical conditions do you have? And for some things that are obvious to me, like Down syndrome or cerebral palsy, our patients don't necessarily can articulate that. And equally, I have some really savvy patients who tell me I have autism, and that means that I need this, this, and this. So it's clear that they had a transition process and worked on it. So I definitely think that just using a portable medical summary with your primary care provider helps our patients become more engaged in their care. And then the other opportunity is it allows providers who are receiving the medical summary to kind of review new guidelines on the chronic care for their condition. So one tool that I really like, and I think you'll all have access to this presentation, is Sick Kids My Health Passport. This is a tool out of Canada, and I know there are other tools. I just happen to really like this one. And it's a really great way to start to organize information about your chronic condition and have it in a portable way. So you go to this Good to Go transition program, and it actually creates a portable medical summary with check boxes and things like that. The other really fun resource that I think that we should all be working on, and I would love schools to embrace this in their system, but if you think that our HIPAA laws are challenging, the FERPA laws are even more challenging in protecting our patients information, but I still think that it's important to kind of go through these steps and learn these skills before you leave school or your pediatric system. And again, by no means do I think this is unique to people with intellectual and developmental disabilities. I can tell you part of our training is in adolescent medicine, and I did my adolescent medicine rotation at the University of Delaware. And so we have smart college students who are coming and leaving their families for the first time and accessing the health center, and you ask them what their allergies are and they're like, you're gonna have to call my mom. And the reality is, I'm not going to call mom. So you're going to have to know what your health information is. And there are times when even our folks with intellectual and developmental disabilities don't have their families around and unfortunately need to access emergency care. So having a way to have that portable medical information on their person or accessible is also important. One of the tools that I encourage my families to use is the emergency medical information in your iPhone. Many of our patients carry their own iPad and iPhone, and there's a lot of great information in there. So Healthy Transition New York developed these series of videos. See one, do one, teach one is how we say it in medicine. Learn one, see it, do it is how they describe it. And they have videos on how to schedule an appointment, making sure you can get your insurance. Guardianship is another really big topic that we talk about in transition. For me, I trained in a fairly progressive state in really more supported decision making as opposed to guardianship. I found that when I came to Delaware, guardianship was a way more advocated avenue. I'm not sure that's in the best interest of all of our patients, but certainly it's one of the things that we discuss in the transition process. Again, I've already spoke about helping our patients understand what their medical needs are and their disability and how to ask for accommodations when they're accessing care. So Healthy Transitions New York has, again, some really great tools that you can incorporate in your IEPs. Start to bring this information to your schools and asking for training in these life skills that are really vital for their health. So again, in the consensus statement from my colleagues, pediatrics, family medicine, and internal medicine, age-appropriate preventative care, as I pointed out, is a huge barrier from the very beginning, and still have significant challenges overcoming them. Let me just see what the next, and again, making sure that we do it in a developmentally appropriate way. For many of my patients, pediatric care, as our guidelines change, access to reproductive health care really went to after age 21. So many of my pediatric providers weren't talking about reproductive health care. It was one of the big barriers we identified in this patient population, is just talking about sexuality and appropriate reproductive health care, and really just having access to talking to the doctor about reproductive health care and sexuality. At RISN Center, we were able to get a grant through the IHC to help really develop some better tools and resources for improving that access. And one of the things we developed is educating, and this initiated with women's reproductive health care. We know that really this should span across just our population for anyone with intellectual and developmental disabilities, to improve just a good dialogue. We developed the 5 Ps, and that just talks about when we're having relationships, even if they're not physical relationships, and even how we interact with our physicians, that we should always be asked permission, that we have privacy both for personal care, but certainly if we're talking about intimate relationships, but even in our doctor's office, doctors should always ask permission before we touch anyone. That's even if we're just talking about touching heart, listening to heart and lungs. If our patients require personal care, we get more privacy and we ask permission before we just, change them in an office, and certainly you never should do it in public areas. Pleasure. So while many of our reproductive health services, like getting a pap smear and cervical cancer screening, aren't pleasurable, we want to make sure that they're comfortable and that they're prepared for them. As we embarked on this journey for getting better age-appropriate preventive care, especially around reproductive health care, we originally had said prevention of pregnancy, but what I learned is that there are many of my patients who actually do want to have families in the future, and so making sure that we have safe pregnancies. So we just changed it to pregnancy, and then prevention of STDs, which is always appropriate. Do I always get to everything? No, we base that on the developmentally appropriate language, or where our patients are on that continuum. So when we're talking about transition and all the behavioral changes that go along with adolescence for every patient, not just people with different abilities, we have to talk about the social emotional changes, just separating from parents, having more personal identity, the cognitive changes, have a little bit more impulse control, again, might need they have a greater need for impulse control. They don't they sometimes just spurt out what they want to say, and we need to give them a little bit more time, and really trying to figure out where they are in their moral standards, and they're still working those out. So we have to give them the appropriate time and resources so that they can be engaged in their care. And for many folks with complex conditions of childhood, I kind of call it the persistence of adolescence. We are kind of going through this phase longer with people with different abilities, and we have to be patient for that. And so that's why finding primary care who understand where some of our patients are, or at least having their families advocate for them to help us know where they are in that continuum of becoming an adult. And also just recognizing that maybe not everyone will achieve the highest levels of medical decision making and will always need some support. But that's where these developmental milestones can be really helpful in making sure that we have enough time in our doctor's office and things like that. So I mentioned some of the services that I receive referrals from, and services that families can ask for if they're already in some of these systems. Obviously, this isn't exhaustive, but just to point out some examples, and you should be asking your physicians or your tertiary care centers what resources they have. So you can make direct referrals, I know, at least at Nemours and at CHOP, to have a transition meeting. At the Children's Hospital of Philadelphia, they have the MINT program. At Nemours, they have the transition of care consult service, that if you're ever admitted in the hospital or if you're already seeing a service, you can ask for that referral, or you can self-refer. Children's Hospital also has another program in Princeton, so you don't have to travel all the way to Philadelphia in order to access some of those services. But I would just encourage you to ask wherever you're getting your pediatric care what kind of transition of care consult services they might have, that will help you develop that portable medical summary, that will help start to prepare your loved one or yourself, or the patients that you care about, how you can use systems to help you develop some of those skills, and then the portable medical summary, so that you are prepared to enter into adult services. So again, I mentioned early on that that original consensus statement was published in pediatrics, but my internal medicine colleagues through SGIM, Society for General Internal Medicine, and also the ACP, which again is our national organization, are developing some toolkits, both so that we can have high value care, but also just access to medical readiness, helping our patients become more autonomous. I think I'm going to go back very quickly. One of the tools that we developed in SGIM, we actually wrote a book on caring for adults with chronic childhood conditions. It's a mouthful, but it's really a great tool to start with. So maybe a shameless plug there. I do have a chapter in there. And sorry about that. So this is the toolkits that the ACP developed with different specialties, really to look at that. The pediatrics journal, I guess, has a lot of really great transition tools. They were mostly developed for genetic conditions. What I really found and what I rely on a lot is a tool called Gene Reviews, which is again more about genetic syndromes, but at the end of that gene reviews, when you pick a specific condition, they have a lot of great parent resources at the bottom, and those resources I find can be even more helpful to me than some of my medical journals. So I use them to connect families with other families so that they have who've already done this process, and then also helps me maintain really what up-to-date guidelines they have for just routine preventative care for different patient populations. Like women with Down syndrome are much less likely to develop breast cancer, so maybe we don't have to do mammograms as often. So not subjecting our patients to uncomfortable procedures if we find data that actually validates that it's not necessary. So, and then finding the ones that are necessary and making sure that we do those screenings early so that we can improve quality of life. So these toolkits are starting to come out more and more and helping us really on the adult side transition that information to the people who are receiving patients from pediatric systems. So we did mention that transition, there's a lot of different things that come with transition. I mostly was speaking about just accessing medical care, but as you already heard in this presentation, that insurance piece, talking about decision making and guardianship or supported decision making, which is something that I highly endorse, at least finding out about it, making sure financial stability and the trusts and things like that. I think that this conference will provide you with a lot of information about these other aspects of transition that you need to consider as our families are successfully going from pediatric to adult care, you know, living independently or at least in group living, and where they're going to work and what kind of day programs and social opportunities are there out there. So I'm hoping that you'll get to see a lot of that in this conference, especially that are local to you. Because what we're hoping for is that we know that one size doesn't fit all for especially our patients with intellectual and developmental disabilities and physical disabilities, and getting more to equity in their care. So if I didn't address items that you would have more questions about, feel free to email me at risn@rowan.edu. I'm just going to talk a little bit about our practice, just so you know who we are, and just give you a little more information. So RISN Center, Rowan-Virtua Integrated Special Needs Center, started in 2019 in South Jersey. We are the first primary care practice with embedded behavioral health and care coordination services for people with intellectual, developmental, and physical disabilities. and their families. So you do have to be a primary care patient. So we are exclusively a primary care practice. You get 3 touches when we meet you. So you meet with the primary care physician. It's usually about an hour-long meeting so that we can learn about you. And hopefully it's with a portable medical summary, but if not, we help guide you through that. Then you meet with our social workers who do a biopsychosocial assessment, making sure that you have connections to those community resources that you need. They also help us with durable medical equipment needs, especially in those transition periods, and make sure that you're starting to look at those other agencies that give you and make sure that you're eligible for those services. And then you meet with our clinical psychologist and you get to hear from Dr. Ada, who is my co-director at RISN Center. She's a clinical psychologist who does a psychodiagnostic assessment, basically so we can get baseline of your behavioral health needs. And what we really focus on is what behavioral health needs do you need in order to access routine preventative health care, because we are really striving to reduce that disparity of people not getting access to routine blood work because of previous trauma. So Dr. Ada talks about that in her talk, and I encourage you to listen to that as well. We equally know that we can't take care of every patient in the tri-state area who has intellectual, developmental, or physical disabilities. So we also encourage our physicians in the community to reach out to us if we can educate them more on how to get better access to services that they want for their families so they can stay in their medical home. So we really want to make sure that we focus on that care coordination piece. So that again, our patients don't have to cross bridges and they can access care in their medical neighborhood. And with that, I say thank you.